Aloha mai kako, and thank you so much for participating in this year's mini medical school. And thank you so much for your support of our university. And Kamal, thank you for the introduction. As you can tell, I am a proud graduate of the John A. Burns School of Medicine and other graduate programs here at the university, so I thank you for your support. Today, we're speaking about osteoarthritis of the knee and the perspective of a physiatrist. So that is who I am. I'm a physiatrist. So you might ask, well, what is a physiatrist? I'm sorry, did you say psychiatrist? Or are you a physical therapist? What is a physiatrist? Well, physical medicine and rehabilitation, PM&R physicians, we're also known as physiatrists. And we treat a wide variety of medical conditions affecting the brain, spinal cord, nerves, bones, joints, ligaments, muscles, and tendons. And we treat a wide spectrum of age groups. Now, we go to 4 years of medical school, and then we do 4 years of residency. And then many of us will go on to another year or two of a fellowship program. My subspecialty is sports medicine, but there are folks who go into pain medicine, spinal cord injury, pediatrics, neuromuscular medicine, brain injury, cancer rehab, and palliative medicine. I just wanted to chat a little bit about my specialty because I think it's important to know that physiatry really focuses on a person's function. How are you functioning in your space, in your world? And that is our raison d'etre. What can we do to improve your function? We also really work as a team, focused with multiple people in our teams, and we really try to preserve and foster a holistic perspective. So with that in mind, let's sort of move forward and talk about osteoarthritis. Osteoarthritis is the most common form of arthritis. It's also known as wear and tear or degenerative arthritis. And sometimes patients say, oh, doc, you mean old age? No, not old age arthritis, but more wear and tear. Because some people who are young also get osteoarthritis. And now osteoarthritis is typically known as the non-inflammatory arthritis, compared to rheumatoid arthritis or things like gout, which is called an inflammatory arthritis due to a crystal, uric acid. This is wear and tear arthritis. It is the leading cause of all musculoskeletal diseases in the world from the perspective of disability. And it is the 11th highest contributor to global disability, period. Now, in America, 70 to 90% of Americans above the age of 75 have some form of osteoarthritis. And that means about 27 million Americans affected. Now, if you then bring that down just to osteoarthritis of the knees, then we're talking about 28% or so of Americans over the age of 45 who have knee osteoarthritis. Significant impact. Now today, I'm speaking about knee osteoarthritis because we just have 45 minutes to chat. But osteoarthritis is also found commonly in the hip, in the shoulder, in the hands, and throughout the spine. So what you learn today and what hopefully you'll learn can be sort of put to any joint or any thought of function and joints. So let's proceed. What is osteoarthritis? Well, you know, the joints in the body come together and there are smooth edges that they come together. That's called the joint. The joint is then covered with this hard but yet elastic substance called cartilage. The cartilage is smooth, and when your chassis is young, when your car is young, it's moving smoothly and not bumpy and creaky. Well, that's the joint of a normal joint to your left. Well, let's move to the osteoarthritic joint. Now you can see in this joint, this is severe arthritis, where you really don't have much of a joint at all. You have pock marks within the beautiful joint that you see on the left. You see the development of these spurs. They're called osteophytes. Have you seen your x-rays recently? Or if not, ask your doctor to show you and see if you have these spurs. The spurs are not what's causing the pain, but they're a result of the wear and tear in the cartilage. And we don't know specifically one cause of wear and tear, but osteoarthritis is the wear and tear in the cartilage due to many factors. And we're going to talk about that shortly. Well, here are some pictures. These are pictures, first of all, here in the left upper corner of the hand. And this is a typical picture of a person with hand osteoarthritis. It's typical because of these bumps at the end of the fingers. These are called Hebridean's nodes. The joint, since you are all medical students now, the joint is called the distal interphalangeal joint, or the DIP joint. And then there are these nods or nodules or wear and tear in the PIP joint, the proximal interphalangeal joint. Those are called Bouchard's nodes. So you have Hebridean's nodes and the Bouchard's nodes. Those are typical of osteoarthritis. But what about rheumatoid arthritis? Rheumatoid arthritis is different. Most of the wear and tear or the changes in the joint occur at the metacarpophalangeal joint or the knuckle joints. Well, let's look right below the hand. What do you see here? How would you describe those legs? Well, most people would say it's bow-legged. Yeah, bow-legged. It's bow-legged because the inner part of the knee joint is collapsed, and so the outer part sort of bows over. This is a typical representation of a person with knee osteoarthritis. Bow-legged, large joints from the osteophytes. Well, let's move over to the right. Who knows what this is? It's a spine, right? What part of the spine? It's the lower back. We call this the lumbar sacral spine. So this is the L5, 4, 3, 2, 1. And what are these things sticking out? They look like bird beaks, the beaks of the bird. Those are osteophytes. Remember the joint spurs I talked about? It happens in any part of the body where there's a joint. So this spinal picture here shows the osteophytes, which are significant. So osteoarthritis can happen in any joint in the body. The hip joint here, it's kind of hard to see, but the left hip joint, this is looking at you front view, so the left is on my right. But this is the wear and tear of the hip joint. So osteoarthritis, remember, is cartilage wear and tear, and it happens in different parts of the body. But today, we're talking about the knee joint. So what are the risk factors? Well, I'm sorry to say, but one of the main risk factors is getting older. Shoots, I wish I could have avoided that one, but I can't. So age is the #1 factor in the development of wear and tear. It's like your car may be 10 years old. They might have a little creaks and crunches when you go over the joints. When you go over the bumpy road, it's not as smooth. Well, when you get older, same thing happens. What's another risk factor? I've underlined the top 3 because those are the 3 most important. Joint overload, stress, trauma. I see in my practice sometimes 30-year-olds who blew out their knee. They had an ACL disruption from football or volleyball, girls, or soccer. I see a lot of women now with early osteoarthritis because of old sports injuries in high school or college. So trauma, that's an obvious one. Stress, repetitive lifting and twisting if you're in a heavy job as a laborer, or twisting and jumping. Now people ask me, Doc, but I like to run. You mean I can't run? No, you can run. Running is okay. Now if you're a recreational runner 3-4 times a week, maybe 2 to 3 miles, and just running without torquing, twisting, and jumping, there's no research that says that's going to give you more early osteoarthritis. If you're a marathon runner, that might be a different story. Or if you're a soccer player, torquing and twisting, you'll be more at risk for the development of OA osteoarthritis. Oh, what is the third factor? I know you don't want to listen to this, but obesity. And you know the obesity curve in America is growing leaps and bounds. Every year there's a higher percentage. Well, obviously, the heavier you are, there's more pressure on your joints. We don't have time to talk about these other factors in detail. For race, it tends to be a little bit higher proportion of Black Americans, Native Americans, and in Hawaii, Native Hawaiians and Pacific Islanders, especially the Polynesians. There's some genetic predisposition, and there's recently some genes, that genetic markers that have been identified that may be linked to early onset osteoarthritis, but research continues on. What about gender? Okay, who do you think gets more osteoarthritis? Women, raise your hands, or men? Women, men. Well, both of you would be correct, so you don't have to fight later on. Both of you would be correct, because up to age 45 or 50, men get the prize. After age 50, women get the prize of having more. Now, some of that could be hormonal, with menopause, decreased estrogen. Estrogen may be saving your joints. Some of it is that men, theoretically, are a little bit more aggressive on their body in sports. There may be other reasons, but women surpass the men in frequency of osteoarthritis after the age of 50. Weak muscles. We're going to talk about this more, so I'm not going to dwell on this, but weak muscles are an important factor in the development of osteoarthritis. Remember this. I'm going to or maybe I should give you a quiz. Kamal, can we give them a quiz later? So take some notes. Remember the risk factors, because if you know the risk factors, then you will know the prevention. All righty, here we go. Symptoms and signs. So this is what a medical student, you, will be learning about your patient. Symptoms are what the patient tells you. Signs are what you visualize on exam or what you see on the test, like x-rays. You got it? Symptoms, signs. So typically the development of osteoarthritis in all joints, but especially in the knee, it's gradual, slow onset, achy pain, gradually progressive. Now, sometimes it can present with some action. It could be the straw that broke the camel's back, if you will. Some activity. And doc, I tripped and I got a lot of knee pain. Well, it could be that you sprained your knee, but underlying that is the development of osteoarthritis, which had been developing for years. But usually it's gradual, slow. Stiffness, loss of flexibility. These are some of the things that the patient will tell you, doctor, and you will see in the patient. Swelling, tenderness over the joint, crackling, popping, grating, locking. These are things that are mechanical in nature. Increase in falls and fractures. Now, this is an interesting thing. Patients with knee osteoarthritis have been found to have increased falls and fractures. Why? Why do you think that might be? Yeah, it's because they're in pain. They might fall. Secondarily, develop weakness because of pain, decreases their ability to walk, put at risk for falling. What else? Associated back and neck pain. Remember, we talked about osteoarthritis being not just in one place. If you have it in one joint, you probably will have it in different parts of the body because the main risk factor is aging. So the more we age, more areas of our body will have the wear and tear. So associated back and knee pain, bone spurs seen on x-rays, that's one of the signs. Remember the pictures I showed you? Heberdine's nodes and Bouchard's nodes, the bumps on the hands, or in the foot, bunions. How many of you have bunions? And a lot of say, because my mom had bunions, I have bunions. Well, that could be that your mom had flat feet, and that's a development of weight bearing causing bunions. That's a sign of osteoarthritis. Weight gain and muscle loss is a secondary effect because you can't move. So those are the symptoms and signs. If you have questions, jot them down because we'll talk about them at the end. So doctor, now you know sort of the reasons why we're going through osteoarthritis because it has an impact on society. And in your patient, you can see the significant symptoms and signs. But this is what we actually see in life. It's a vicious cycle. How many of you have heard about vicious cycles? There's vicious cycles. Unfortunately, I shouldn't talk politics, but sometimes there's a vicious cycle in the downward trend of fighting in the political realm or in the social realm. This is a vicious cycle in the personal body based on knee osteoarthritis. Let's say your joint becomes painful. What do? You don't move it. What happens when you don't move the joint? The joints become stiff and your muscles become weak. You can't get up because it hurts, you're weak. What happens? You get out of shape. Cardiovascular conditioning diminishes. When you can't move, but you continue to eat, what happens? Weight gain. When you are heavier and you have less motion in your joint, the joint is not protected, you have more pressure on the joint. Further decrease in range of motion, worsening arthritis and pain, and you go to the top and you keep going and going and going. Now think about this. Remember this in your mind, the vicious cycle. Because what we need to do as many medical student physicians, as significant others, as aunties and uncles, grandma and grandpa, we need to be sure to understand this vicious cycle and what we can do individually and talk to our family about breaking the cycle. So how can we break the cycle? Who has some answers on that? Well, we got to stop the cycle, but we also have to start the rehab. So I'm going to talk about this. Okay, this is the crux of our discussion today, all right? First, we need to protect the joint. Secondly, we need to reduce pain. And most importantly, we need to have a rehab program. And I say we need to stop the cycle and we got to start a rehab program. Because I am a physiatrist and we got to focus on getting you at a better level of function. Not just taking pills to decrease pain, but to improve your function. So we're going to talk about each of these areas in a little bit detail, all right? I hope you guys don't mind. But we're going to talk about the joint, protecting the joint. Long term, the best way to protect the joint is to decrease weight. Well, in the meantime, as soon as you get the knee pain, what are you going to do? You want to decrease weight on the knee. You can use crutches, braces. I brought today, I was going to talk about this later, my walking sticks. I could use one of these in the acute sense. I use these for my rehab. But you want to decrease pressure. So if you're going to use a cane, let's say my pain is my right knee. Oh, my right knee hurts. What side do you put the cane on? The right or the left hand? All right? I'm going to ask you that question. Jot it down, see who's right. Well, let's move on. We're going to go through each of these in detail. We're going to talk about reducing pain with ice and medicine and injections. We're going to move that into a rehab program. And let's sort of talk about these individually. You guys ready? Let's go. Protect the joint. Remember we talked about weight? Now, I'm not talking about the acute weight because you cannot lose 10 pounds in one day. Well, you could, but that would be dangerous. So we're talking about long-term loss of weight. Think about it. The body is here, and then the knee comes down to a pinpoint. So if you gained 1 pound, you're causing all this pressure to come down in a vector force to the knee. Just by standing, 1 pound weight gain above, most of it's the body weight, increases 3 pounds on the knee, just standing. Once you start walking, it increases by 5 pounds. The vector forces because of the gravity. Once you start running, it increases by 7 pounds. So I should have put 1, 3, 5, 7. Easy to remember, they're odd number projection, movement forward, 1, 3, 5, 7. Remember that. So if you gain 10 pounds, holy cow, walking, you put 50 pounds extra on your knee. It's a huge amount. And that's why the studies have shown weight loss is a significant treatment long term in preventing progression of osteoarthritis. Well, in the short term, you can use a cane, and you use the cane in the opposite arm of your knee. Why? Because you're moving the center of gravity away from the affected knee, and that's why you're shifting it to the opposite arm, okay? Oh, the other thing is when you go upstairs, you go up with the good. I'm going to heaven with my good knee. And I'm going down to the other place with my bad knee. Going up with the good, going down with the bad, just to protect the amount of ground reactive forces. Is this helpful? Hopefully it's helpful because we're talking about simple things to protect the knee. This other one, you know, the offloading knee brace, we're going to talk about this a little bit more, but they're I don't know, $1,000, maybe more. They're really expensive. but it's about one of the few things that have been shown by the American College of Rheumatology, looking at all these studies historically, to be something that can decrease pain and is significant. But it's expensive, it's cumbersome, and we'll have to talk about that in the breakout session later. But bracing can be helpful. My caveat to you is if you wear a brace, don't use it all the time. Why? Because your own intrinsic muscles will deteriorate, and then pretty soon you cannot go without the brace. And I've seen that in many of my patients. So what's the first thing we do to break the cycle? Protect the joint. What's the second thing we do? Reduce pain. Okay, so you've heard of rice, yeah? Everyone's heard of rice. I mean, not the kind you eat, but the rest, the ice, the compression, the elevation, yeah? I put the P in front of the rice and said price, because you're going to pay the price if you don't listen to price, yeah? Price, what does that mean? Just protect the joint, what I just said, and then follow through with rest. Oh, but did you guys learn rice with the word rehab in it? Probably not. Did you learn range of motion, R? Probably not. It's really important. I want to emphasize that you don't just rest the joint, but as long as you have no fracture, and if you don't know, you have to see your doctor, get an x-ray, but you want to get range of motion, and you want to start getting some strength in the leg. So, rest but rehab. Compression is just to decrease swelling, and then elevation, you know what to do. So, the question, is it ice? Is it heat? Doc, which do I use? What is the answer? Yup, you got it. Ice is in the acute phase, right? You want to use it in the first 72 hours. Why? Because ice will decrease swelling, inflammation, pain. So that's the time to use it. What about heat? Heat's more in the chronic stages when no swelling, redness, warmth, heat, but more stiffness, like in the morning when you wake up or before you exercise. Most of the heat is put around the muscles rather than the joint, just to warm up the muscles before you move. Now, for either of these, you don't want to use for greater than 15 to 20 minutes at a time. You don't want to apply ice directly or heat directly to the skin, but a little interface between. Although our athletes in high school, we just pile it on because they're young and they can take it. But we tell them not to leave it more than 20 minutes. And never put ice or heat directly on a nerve where the nerve is passing through. And if you have poor circulation, don't put it on the tips of your toes or hands. So, let's move to the medicines. How many of you take Tylenol? Tylenol is not bad. Tylenol in the past was recommended by the American College of Rheumatology as the first-line treatment for pain. Now, I must say that the American College of Rheumatology put out a new guideline last December, this time, 2019, and they said that Tylenol is not as effective as anti-inflammatories. You know the Motrin, Advil? But it's a lot less dangerous, especially for those above age 65. So I still feel Tylenol is safer than the others, and no more than 3 grams. Remember in the old days they say 4 grams? What is grams? 1,000 milligrams? And how much is extra strength Tylenol? 500 milligrams. So no more than extra strength Tylenol, no more than 6 a day. Now, it is for pain. It doesn't do anything for inflammation, but it won't affect your kidneys. And if your liver is okay, at that level should not affect the liver. Non-steroidal anti-inflammatory drugs are shown to work. But what's the problem? Just think in your mind while I drink some water. What is the potential problem with anti-inflammatories? Got the answer? Well, anti-inflammatories tend to bother the stomach lining. And when you age, you get thinner stomach lining, so you're more at risk for bleeding ulcers, gastritis. When you get older, your kidneys are not functioning as well, and the anti-inflammatory medicines can cause damage to the kidney without you knowing. And ulcer, eventually you'll have pain. Kidney damage, you won't feel anything. So for me, cardiac. For those of you who have hypertension, cardiac problems, history of heart disease, congestive heart failure, you have a stent, anti-inflammatory medicines have shown higher risk of cardiovascular events. So I think for me, a little bit dangerous above age 65, unless you've been cleared by your internal medicine, family medicine, physiatrist, whoever you're seeing. Okay, narcotic pain medicines. Oh, you've heard of the opioid crisis, haven't you? Well, it's a true problem. And there's some older patients who have osteoarthritis who've gotten hooked on narcotics. So it is, again, recommended not to start narcotics unless absolutely necessary. And the one to start traditionally is tramadol has been felt to be the safest. Topical medicines. Of all the topical medicines, the only one that has come out pretty well as being a positive as far as guidelines are concerned is diclofenac, or topical anti-inflammatory medicines. Now, I must say, I am not recommending any brand names at all. I never do. But if you look at and talk to your pharmacist about the topical anti-inflammatories, those are the ones that have been studied and shown to have some effect for knee osteoarthritis. I don't have a whole lot of time to talk about everything else, but it's sort of listed here. Methylsalicylates, you know, the Bengay or the Icy Hot, those are made out of these salicylates, sometimes with menthol. And what does it do? It irritates the skin to make it feel cool or warm, but it doesn't do anything more. It's just a skin irritant. And there's no proof it works, except it smells like it's working and it feels like it's working. So my feeling is, as long as it doesn't cause a rash, okay, you can use it if the person next door to you doesn't faint because they're smelling it all day. But anyway, it doesn't necessarily work. Capsaicin, you guys heard of that? Oh, it's made out of the chili pepper. Oh my gosh. So the problem is, I mean, there's some information that it might work a little in knee osteoarthritis, but could you imagine putting on your knee and then touching your eye? So we recommend if you use it, don't put it on your hands. Don't use it on your hands. Use a Q-tip, put it, but I don't recommend it. I recommend topical anti-inflammatories. Lidocaine, you guys heard of that, right? No, lidocaine patches were never over the counter. The diclofenac or Voltaren cream was never over the counter. Now they're all over the counter. So be careful now. The lidocaine patch just numbs up your skin, so you're not going to feel pain. That's all it does. Well, let's move on because I have so much to talk about. And I'm going to go gradually quicker and quicker if we're running out of time. But it's all in your handouts. Injections. Who's got an injection here? Steroids. Oh my God, what's the term steroid mean? Steroid is a big term, okay? It's a structure that's made, steroid, a hormone. And then steroids are into different things like the female steroid, estrogen, and then the male steroid, testosterone. And then you got the non-female, non-male male called corticosteroids, where I'm talking about those corticosteroids, not testosterone. We're not going to inject with testosterone for your knee. But that's what I mean by steroids. It has been tested, the corticosteroids, and found by the studies, by the American College of Rheumatology, to have a positive effect. The problem are the side effects. It can cause, you have to rest after the injection, because if you don't rest, the cartilage gets softer. And if you start pounding and running and jumping, it's going to cause more advancement of your osteoarthritis. We used to, we cover football games. You know, I've been the doc for UH and Puno and a whole bunch of things. The Hula Bowl, you guys might remember. It's an all-star college bowl. Every year I would go, and who are the scouts? The former NFL players. You remember the picture I showed you with the bow-legged? Yeah? The cowboy look? Everyone, I should have taken a picture of this. Every one of those former pro players had the bow legs. Why? Because they, in the old days, got cortisone shot into them. Go back in the game. And they played week after week with cortisone. It deteriorated their joints to the point arthritis. Anyway, skin changes can occur, infections. If you have an infection, if you have a bleeding disorder, if you have high blood sugars like diabetes, we're a little bit cautious about cortisone. Cortisone can cause flushing of the skin, insomnia, agitation, you know, and it doesn't prevent joint damage. It just decreases inflammation, but it does help pain. But why would we want to break the pain? Remember that cycle? So sometimes you can break the pain cycle, but if you don't do anything else like rehab, then all that cortisone is for naught. Waste time. As we say in Hawaii, poho, no sense to use them. Yeah. Anyway, so that's cortisone. It typically, you can do it no more than 3 or 4 times a year. I don't like to do it even 1 time a year, but I will if needed. And you have to modify your activity after the injection. You gotta at least wait 3 months if you get cortisone before you get a total knee replacement. So I work with Cass Nakasone and Joe Vakardip and some other people. They won't even do a surgery on replacement if you had a cortisone shot within 3 months, because it may increase your chance of infection. So, have you guys heard of Synvisc or Euflexa or Duralane? You know, these are called viscose supplements. They are made of hyaluronic acid. And their hyaluronic acid or hyaluronate is sort of the building blocks of the lubricating fluid in the knee or in joints. It's only FDA approved for the knee. It's sort of the fluid, it's the lubricant. I call it a lube job. It's the lubricant that's found in the joint. The old ones were made from the chicken comb, the lepe ula, the red thing on top of the chicken, and was grounded and macerated and purified to Synvisc and others. Those are called the avian. Then the non-avian branch are made in test tubes from bacteria, almost like a fermentation process, where the bacteria would then spew out all of this hyaluronic acid, and it's pure form. So we like to use the non-avian. I must tell you, there's no strong proof that it works. And the American College of Rheumatology said, don't do it unless you tried everything else that didn't work. But I do it, I suggest it to my patients if they want to avoid surgery, because a lot of people actually get better on it. So that's the viscose supplements. Biologic therapies, I could spend hours on this. I'm not going to say anything except there's no proof it works, period. And it's not covered and approved by the FDA. And platelet-rich plasmas, at least 600, maybe $1,000. Stem cells, you've heard of, maybe a couple thousand, no proof at all. Potentially some side effects, and until there's good proof, unless you have a lot of money to spend, and you be sure to talk to your doctor, because there are some potential side effects, I would not recommend biologics yet. This is the last injection. How many of you heard of radiofrequency ablation of the genicular nerve? Not too many. We do it at Straub and other places within town, and it's basically a needle that goes on the nerve and burns the nerve so you don't have pain anymore. But before you do that, you put these numbing medicines, and if it works, then you burn the nerve. The American College of Rheumatology says that it's okay, you can do it because there's some proof. But that's only if you're not going to get, or you cannot get the knee replacement, and you've tried everything else. So we spent a lot of time. I'm going to move progressively here because we got about 15 minutes more about rehab, because that's the most important. Remember, I talked about physiatry and the importance of function. Remember that. In fact, I tell my second-year medical students, and they rotate with us to learn about the physical exam, I said, if you don't put function in your report when they see a patient, then you get a big F. F for function. I never failed any student. I'm just saying it's such an important thing in our lives. So the rehab, motion, joints love motion, strength. Strengthening is done. Now, this is usually done under the guidance of a therapist. And I brought one of these rubber bands because it's not really pounding, but it gets strength. And then you want to talk about cardiovascular and activity modification. I want you to remember that the most important aspect of the treatment of knee osteoarthritis is what we're looking at now, a rehabilitation program. Most of my patients say, hey, doc, can you shoot me up? I mean, I think they're meaning with cortisone. Or, doc, can you give me a bunch of medicines? Because don't we want a quick fix in our lives? Don't we want something that'll quickly fix things? Well, I'm sorry to say, when there's osteoarthritis at the later stages, even the middle stages, we can't reverse it. We can't fix it, but we can prevent worsening. And the best way to prevent worsening are 2 things. What are they? Weight control, if you're heavy, and strengthening of the muscles, maintaining flexibility around the joint. So I cannot emphasize this more. I'm not going to talk about detail because you can look at webmd.com, that's one source, and put in knee osteoarthritis exercises. Studies have shown, however, that if you get one-on-one coaching from a therapist, that you do better with a program than just looking it up online. Okay, so remember that. Don't be afraid to go to therapists. They're very good and they can help you. We spent time talking about osteoarthritis. We talked about the vicious cycle. We spoke about breaking that cycle. Now, once you've been diagnosed with osteoarthritis and things are calm, or once you hear that uncle and auntie or brother, sister have it and you want to prevent it, what can you do? Well, you want to prevent disability through improving your fitness, maintaining weight, muscle tone, range of motion, flexibility. Remember, motion is lotion or motion is good. Joints love motion. You want to think about doing non or minimally weight-bearing cardiovascular exercises, balancing exercises, strengthening exercises, weight control with a joint healthy diet. So let's dive into this a little bit. We have about 8 minutes or so to go, so I'm going to touch upon these and hopefully get you motivated. Oh, by the way, I hope you did your homework. Did you do your homework? You remember what your homework was? Your homework was, oh, you forgot already. Shoots. Okay. Your homework was to put a log for about a week and jot down the amount of minutes you're doing some cardiovascular exercise, walking, bicycle riding, a lot of heavy work not heavy work, but work at home, gardening, and put the amount of minutes. And then also put the amount of minutes of actually strengthening or lifting exercises. Well, hopefully you have that because I'm going to have you turn that in at the end of the lecture. So why are we talking about this? It's important because it's fitness. And I can tell you that we are surrounded by water, and we have water in every community, city and county pools. Most of my patients say, oh, it's too cold. But people say, oh, I don't want to go in the water because my body's not that good anymore. I don't want to wear a bathing suit. I don't care. It's wonderful. The people at the YMCA, at the YWCA, at the city and county pools are wonderful. There are some aqua therapy programs and physical therapy places in town. Wonderful. And this is just an example of the exercise you can do. It's group, it's sometimes with music, and it's outside. And it's safe right now in COVID times because you're in an environment that is safe, especially if you're distanced. Tai Chi. How many of you do Tai Chi? I've never done it, but I recommend it to my patients, especially since 2019, December. The American College of Rheumatology said that this is about one of the few exercises that have been shown on prospective studies to improve the pain and function of osteoarthritis. The thought is that Tai Chi is not just one type of exercise, but it's holistic. Remember we talked about holistic health? Tai Chi is slow and graceful, it's controlled movements, it's balance, it's body upright, but it also works on breathing, on calming yourself down, on decreasing stress. So Tai Chi is very important, I think, and there are a lot of free programs against city and county. Yoga. Not as much proof in the literature, but yoga can be helpful. Endurance, flexibility, weight control, breathing, controls stress, blood pressure, low impact, as long as you're not bending from the back if you have back pain. And some studies have shown an improvement in OA. I'm going to touch upon this next subject, and I hate to touch upon it because a lot of people ask me tons of questions, and all I can say is alternative complementary therapies can be helpful, but you have to talk to your physician about its use. About 25% of Americans use herbal and supplements. And this is one of the studies, I think probably more. And I'm going to touch upon a few, is that okay? But I'm going real quick. How many of you have taken glucosamine? I've taken a bottle that I've had for a couple of years. I still take it. I don't want to throw it away, but it probably doesn't work, but I take it anyway. What is glucosamine? It's a major component of a joint cartilage. It comes from shellfish. It might help pain and stiffness, but there are no studies proving it. In fact, the American College of Rheumatology says, no, we wouldn't recommend it because there's no proof, except it might give you a placebo effect. Placebo effect is okay if you don't have any contraindications. So if you're diabetic, it might increase blood sugars. Blood pressure, cholesterol maybe have an effect. So for glucosamine, you got to talk to your primary care physician before starting it. Again, no proof. Oh, by the way, there's this book by the Arthritis Foundation called Good Living with Osteoarthritis. Pretty good literature and talks about some of these alternative medicines. Chondroitin usually comes with glucosamine, right? Again, no proof. But this one might affect blood thinning. And so if you're on a blood thinner or if you bruise easily, definitely need to speak to your physician about chondroitin. How many of you take omega-3? Fish oil, yeah. There is no proof that it helps in arthritis. There's some indication it helps with blood vessels. It's anti-inflammatory, it's an antioxidant. Fish oil, yeah, it's pretty healthy, but you can also get it in your food. 3-ounce servings of fish a week keeps the doctor away. The problem with fish, what's wrong with the deep fish? Mercury and all. You know, the world is being polluted, so you got to be careful with the fish as well as far as mercury and other substances. Plant sources, flaxseed, chia seeds, walnut, edamame. Think about these things. These are good sources. So think about them. I'm going to talk about a diet. Oh, I got 2 minutes. Okay, a diet when we're done. Blood thinning properties again. So be careful, talk to your doctor. Oh, turmeric. How many guys, turmeric? It's been around for a while. Yellow, it's curcumin is the active ingredient. Popular Chinese, East Indian medicine. Hawaiians, we call it olena. Beautiful olena. They're beautiful songs. We make dye for kapa, and it's used for la'au lapa'au. Olena was one of the canoe plants that was brought over by the Polynesians. So obviously there's some effects there, but no proof in the Western literature. High doses of turmeric can also be a blood thinner. Astaxanthin, oh gosh, I'm not pushing anything, but my patients, I take bioastin. You know, it's from the limu, the microalgae from Kona, which is the one that most people use. It's an antioxidant, it's a flavonoid, it's an anti-inflammatory, but no proof. It might help your heart, blood vessels as well. No proof, probably safer, doesn't affect blood thinning. So, supplements. Oh, there's more, but I don't have time to talk about it. What do you do with supplements? Well, there's no standards, like the FDA doesn't watch them like pharmacy drugs. You might have an interaction, especially with blood thinners. May cause lab abnormalities like thinning of the blood or high glucose. So before taking anything, talk to your primary care doc. Promise me that, okay? All right. Oh, here's the menu. I'm almost done because I'm getting hungry. This menu is, I have to say thank you, Dr. Santos Ocampo, because he's a rheumatologist who works with me at Straub. And he put this menu together when he spoke to some patients. And it looks so good, and it includes everything that has an anti-inflammatory effect. Fish and shellfish. Curry with ginger and chili peppers, they all have anti-inflammatory effects. Oh, by the way, you know, all of these anti-inflammatory foods, they're also good for your health because it's low carbs. The carbohydrates, the white stuff in your diet, the sugars and the flours, they are not good for arthritis. They're inflammatory. Plus, they put the weight on. All the Mediterranean diet, all those diets that are good for weight are also good for arthritis. So, the edamames on the side instead of the rice, or maybe you could have quinoa. Avocado and potato salad, and then you have this iced tea or hot green tea. That's the anti-inflammatory diet. Now, I couldn't eat this every night. I could. My wife would kill me. No. but you get the idea. It's these natural foods, the grains you put into your diet that are important. So that's the summary. I'm a physiatrist. We talk function. We work with function. We work holistically. We talked about the knee arthritis, the vicious cycle, how to break that vicious cycle. We talked about the non-surgical treatments. Someone else can talk about surgery later. We talked about prevention. Remember, you all can do it even if you have no OA. And then we talked about alternative therapies. That's the physiatrist, our approach. So, let's see if there, I wanted to share with you some words of wisdom. Hippocrates said, if we could give every individual the right amount of nourishment and exercise, Not too little, not too much. We would have found the safest way to health. He also said that eating alone will not keep a man well. He must also, he meaning he and she, must also take exercise. Thomas Edison, oh my gosh, he said, the doctor of the future will give no medicine, but will educate his patients in the care of the human frame, in diet, and in the cause and prevention of disease. And exercise is medicine was a statement on a global health educational campaign put out in 2007 by the American College of Sports Medicine. And I say, I'm not a scholar in these, but I say whatever you do, exercise, dieting, movement, have fun, and do it with others. I really, really appreciate your attending and your support of our university. And now we'll just open it up to some questions.